Go ahead and get started with the intro. We can go ahead and make this happen.
Great. Thanks, Josh. Thank you, everybody, for joining us for today's InCHIP lecture series. As you might know, it's Heart Health Month, so we are delighted to have the esteemed Dr. Freedland here from Washington University School of Medicine in St. Louis, where he is a professor of psychiatry and psychology. Most of Dr. Freedland's research has focused on depression in patients with heart failure or coronary heart disease. He has also conducted studies of other psychiatric comorbidities, behavioral problems such as poor self-care, and social determinants of health in patients with heart failure. He has been the principal investigator or co-investigator on both single-site and multicenter trials of interventions for depression in cardiac patients, and has served on clinical trial review committees for NHLBI and PCORI. Dr. Freedland also has expertise in behavioral trial methodology. He is the founder of the Society of Behavioral Medicine's Cardiovascular Disease Special Interest Group and of the Behavioral Medicine Research Council, and a fellow of multiple organizations, including the Academy of Behavioral Medicine Research. He was the program director of the annual NIH Summer Institute on Randomized Behavioral Clinical Trials from 2020 to 24, and he has been a member of the Summer Institute faculty since 2007, which is where I met Dr. Freedland and have been delighted to be his colleague there and learn more about his work. And he's also been the faculty of the NIH-funded ORBIT Institute on developing behavioral treatments to improve health since 2022. He has also served as an associate editor of Psychosomatic Medicine and editor-in-chief of Health Psychology. We're extremely fortunate to have Dr. Freedland with us today to talk about his important research on cardiovascular disease and depression. Just a quick housekeeping note, you will be muted until the end of Dr. Freedland's presentation, and at that time, we will unmute you for questions. You're also welcome to put any questions in the chat. So without any further ado, Ken, welcome.
Thank you very much, Tricia. I'm glad to be here, and thanks to everybody who are joining us today. I'm going to be talking about the treatment of depression in patients with heart disease, and let's see here. I don't have much to disclose other than grant support from NIH. Before I get into treatment, I want to talk a little bit about both heart disease and depression and how they may be related, and then talk a little bit about what we know about evidence-based treatments, both how effective are they, but also how safe are they. I want to touch briefly on some collateral effects of treating depression in cardiac patients, and then say a little bit about needs for further research. So just to make sure we're on the same page about the heart diseases that we're talking about, coronary artery disease, or otherwise known as coronary atherosclerosis, starts to develop in adolescence, if not in childhood. And usually people have no idea that they are starting to develop lesions in their coronary arteries until they're in middle age or even older. And so that's one of the things that complicates research in this area, is that depression and other kinds of behavioral and psychosocial problems also tend to start in childhood or adolescence. So these things are all going on without any manifest heart disease. But when the arteries get clogged up, that can turn into obstructions in the arteries that cause what's known as myocardial ischemia, or inadequate blood flow to the heart itself. And that can cause what's known as ischemic heart disease or coronary heart disease. And if things really go bad, then there can be a sudden blockage of one of these lesions in here that causes what is commonly known as a heart attack. It can either be in the form of a myocardial infarction, or there are other kind of related problems that fall under the broader heading of what's known as an acute coronary syndrome. But these are situations that cause damage to the heart muscle itself, and that require typically emergency treatment, either with clot-dissolving meds, percutaneous coronary interventions, sometimes with mesh stents placed into the arteries to keep them open, sometimes with emergency coronary bypass surgery. And then people who have this problem tend to be on multiple medications indefinitely. When we talk about heart failure, there are a variety of different forms and a variety of causes. But two of the most important ways of differentiating heart failure are what's known as HFpEF and HFrEF. So what the difference is in the ejection fraction, which means of all of the blood that goes into the left ventricle, and that's the ventricle that pumps blood out to the rest of the body, what percentage of that blood gets pumped out after it fills up the chamber? You can see, and there's this one form of heart failure called HFpEF, where the chamber is small because the heart muscle has gotten thick and stiff. And so even if a high percentage of blood is getting pumped out, there's not much blood in there to begin with. And so the body is not getting an adequate supply of blood. The other way to have heart failure is with HFrEF, in which the heart muscle gets weak and it kind of expands. So there's plenty of room in there to fill up with blood, but the problem is that the heart muscle is too weak to pump much of it back out again. So that's a situation where the percentage of blood getting pumped out goes down. That's the more common and better known and more treatable form of heart failure. But both of them are problematic. Here's what the world situation looked like in 2019, just the latest data that we have. You can see in terms of the prevalence of heart failure, the United States is a real international hotspot. We have a higher prevalence of heart failure than any other country in the world, and it's growing as the population ages. So this is a real big health problem for us. Just touching briefly on depression, there's been a lot of interest in depression and heart disease. Sometimes when we talk about depression, we mean major depressive disorder, which is in the DSM-5, the American Psychiatric Association manual. In order to meet the criteria for major depression, you have to have either depressed mood or anhedonia, in other words, loss of interest or pleasure in usual activities, and you have to have several other symptoms. There are lots of different ways that major depression can present. It can be episodic or it can be chronic. People can have more or fewer episodes, and you can either have one currently or maybe just in the past. So there are lots of different expressions of major depression. But also when we're studying this problem in cardiac patients, lots of people define depression in other ways that not necessarily corresponding to DSM-5. Like if you hand out a questionnaire like the BDI or the PHQ-9, and people exceed a cutoff score on that, you can say that the person is depressed. And they may or may not meet the DSM-5 criteria for major depression. So both of these ways of thinking about depression have been studied a lot in patients with heart disease. Now, back in the 1980s, when cardiovascular behavioral medicine was just getting off the ground, most people were focusing on type A behavior, hostility, and anger, and also cardiovascular reactivity to stress. Now, my colleague, Dr. Robert Carney, was really the first person to recognize the importance and perhaps the greater importance of depression, and especially major depression, in patients with coronary disease. And I started collaborating with him right around the same time. And so with an early series of articles, it really led to a great deal of interest in depression and heart disease, and a kind of a waning of interest in these other phenomena like type A behavior. And then I went on not long after that to publish the first study ever on major depression in patients with heart failure. Now, since then, there's been an explosion of interest in this area. Over 3,000 papers, and in fact, approaching 4,000 papers have been published in this area, broadly speaking, on lots of different topics. What are the prevalence and correlates and mechanisms of depression in cardiac patients? Does depression work as a risk factor for incident heart disease? Does it affect the prognosis of people that have existing heart disease? How do you treat it? And of course, there have been quite a few meta-analyses by now. So the literature is vast and kind of hard to work through. So I want to just touch on a few highlights. Let's look at meta-analysis of depression as a risk factor for incident cardiovascular disease. In many different studies, is shown up as a risk factor, maybe not the most potent of all of the risk factors, but it is clearly causes an increased risk of developing cardiovascular disease. And I just want to point to the fact that the strongest relationship seems to be with the worst outcomes of cardiovascular diseases. It seems when you define it in terms of death or myocardial infarction, the effect is even stronger. Here is another and more recent meta-analysis where we see, again, the hazard ratio for incident CVD, broadly defined, is 1.16. But when you define it in terms of worse kinds of cardiovascular outcomes like myocardial infarction, the effect gets even stronger. So it seems to be a risk factor for bad things in the heart population. Now let's look at the prevalence of depression in patients with myocardial infarction or acute coronary syndromes. And I want to draw your attention first to estimates that have come from surveys of the general adult population. And in men, the point prevalence of depression runs around 4% or so. In women, maybe 5%, just in broad population surveys. So you can see relative to the general population that even the lowest estimates of depression in people who've had a heart attack is a lot higher than it is in the general population. If we look at does depression predict all-cause mortality in people who've had a heart attack or acute coronary syndrome, now, I want to say these are studies and meta-analyses that lump all kinds of different measures of depression and all different kinds of ways of defining heart disease. And so there's a lot under the hood here, but just kind of to summarize all of this briefly, we see consistently that these meta-analyses show an increased risk of all-cause mortality in patients who've had a heart attack. But compare that on the same scale of hazard ratios to all-cause mortality in patients who have heart failure. And you can see that the effect is pretty profound. Having depression, if you have heart failure, according to the latest meta-analysis, greatly increases your risk of all-cause mortality. Nevertheless, there have been longstanding questions about whether depression is a causal risk factor for these bad outcomes. That's been controversial because, again, the temporal interrelationship between depression and heart disease is so hard to pin down, and also the mechanisms have been hard to pin down. And so the direction of the relationship is controversial, and the causality is. And, we know when depression is predicting mortality, we don't have a problem with mortality predicting depression, but we do have that problem with problems like myocardial infarction. If you see more people being depressed after a heart attack, is it because of the heart attack that they're depressed, or one of the reasons that they had a heart attack is because they were depressed? It gets very complicated to study that. Fortunately, there's been some recent progress on this question with what are known as Mendelian randomization studies. Now, I am not an expert in genetics, and I don't fully understand this newer methodology, but what they are doing in these kinds of studies is using genetic variants that are known as SNPs, single nucleotide polymorphisms, that are strongly associated with the exposure of interest, in this case, depression, and they serve as proxies for exposure. So in other words, these are the genes that create liability to depression, or the genes that cause liability to heart disease. And the nice thing about this is the genes, of course, are inherited before you develop any diseases. And so it gets rid of the problem of reverse causality. It can't be that heart disease is causing liability, genetic liability to depression. So it gets rid of some of that reverse causality problem. And you can study this both. Do the genes for depression increase the risk of heart disease? You could also ask, do the genes for heart disease increase the risk of getting depressed? The thing about this is this requires very large GWAS data sets, and you have to meet certain assumptions. I'm not an expert on this, but there's a nice review paper that you can look at that kind of explains the whole thing if you want to go into more detail. I'll just touch on several relatively recent studies. There's one with over 500,000 individuals, and they found a bunch of genes or SNPs that are related to liability to depression. And these genes increase the risk of coronary artery disease, but more importantly and stronger, increase the risk for having a myocardial infarction somewhere along the line. And conversely, genetic liability to coronary disease did not increase the risk for depression. So the direction of causality seems to be running from depression to heart disease. Another one with an even bigger sample, over 800,000 participants, we found genetic liability to depression increased the risk of coronary disease, myocardial infarction, and heart failure. That's a 2021 study. Now, here is some interesting work that just recently came out in 2024. They looked not only at depression with 47,000 individuals, but also a variety of other psychiatric conditions and lifestyle health behaviors to see how they might be related to heart disease. And interestingly, major depression, there's 41 different SNPs that they identified that are related to the risk of developing major depression at some point. And they found that these SNPs that are for depression actually also predict heart failure, the development of heart failure. Something else that looks like an even stronger predictor is autism, but I'm skeptical about that because there's only one SNP and there hasn't been a lot of research on that. So I don't know what to make of that. But I do think this finding here is interesting and kind of novel. People with the genes that give rise to ADHD tend to also be at increased risk for heart failure. There's, to my knowledge, there's been very little research on that. So I think that's an area of potential interest. But again, this also, again, confirmed that having a genetic liability to depression increases your risk for heart failure. We're making some progress on finding whether there's this causal relationship. That still doesn't tell us whether treating depression is going to improve cardiovascular outcomes. In fact, we don't know that much about it, and the few attempts that have been made to study that haven't all gone very well. We haven't garnered a lot of evidence that treating depression can improve cardiovascular outcomes in coronary disease or in heart failure. Even if it doesn't, though, and we don't know yet, but even if it doesn't improve cardiac outcomes, there are lots of other reasons to treat depression in cardiac patients. First of all, major depression is a clinically significant psychiatric disorder in its own right. It deserves treatment no matter what its downstream effects might have. But also we know all kinds of chronic illnesses can make it harder to cope with life's other problems. And typically when people start to develop heart disease, and especially heart failure, that's not the only medical problem they usually have. Those go along with other medical problems. So as people get sicker and sicker, they have trouble coping with other problems in their lives. The chronic illnesses themselves can be difficult to cope with. And conversely, the other problems that you have in life may make it harder for you to cope with your medical problems. And of course, we know there's a very strong relationships between pain and functional disability on the one hand and depression on the other. And finally, we know that depression is a barrier to self-care of chronic illness. So there's all kinds of reasons to be interested in treating depression in people with heart disease. Now, typically, if you have heart disease or whether you don't have heart disease and you go to your family doctor or primary care physician, you're very likely to get handed an SSRI antidepressant like sertraline or citalopram. That's usually typically what people get. And sometimes they're just put on that and left on it, whether it's working or not. And there's some evidence about whether they work in heart disease I'll get to in a minute. I've been more involved on the non-pharmacological side, and especially with looking at cognitive behavior therapy and some other interventions, but especially cognitive behavior therapy. They've shown some promise, but they aren't very widely used in medical practice, and cardiologists don't tend to refer people for cognitive behavior therapy, at least not yet. So if you're a heart patient, you're likely, and you're significantly depressed, what's most likely to happen is you're going to be given an SSRI antidepressant. Now, the challenges in doing research on this are, first of all, confounding by indication, which means that the reason people get antidepressants is often because they're depressed, right? And so when you do observational research, it's hard to disentangle between the effects of depression and the effects of being on an antidepressant. They're all kind of tangled up together. So which is it that's causing bad outcomes? Is it depression or is it the antidepressant? And then also, as I've alluded to, some of the highest impact trials have not been very encouraging as far as whether treating depression produces good results in cardiac patients. So I want to go back to one of the first and most influential trials. This was the sertraline antidepressant heart attack randomized trial, or SAD-HEART. This was a multicenter trial out at Columbia University in New York. They randomized it was a multicenter trial. They randomized 369 patients to sertraline, this commonly used antidepressant, or to a placebo. And in the main analysis, they found no significant difference between sertraline and placebo on the Hamilton Rating Scale for depression. So overall, it did not show efficacy. They had a pre-planned set of subgroup analyses, and you see that in people with more severe depression, there was a significant benefit for sertraline. But when you get down to it, it's only like 2.5 points. It's not a whopping effect. So you have to say, as is often the case, it's difficult to see any benefit in treating relatively mild depression. It's hard to show benefit for any kind of treatment. It's easier to show benefit when people are a little more severely depressed. But this commonly used antidepressant just is not that great, even for people with pretty substantial depression. And here, in some of the findings that came out of this study, we see that if you have relatively severe depression, your chances of dying are a lot worse than if you have milder depression. But if you got randomly assigned to sertraline rather than placebo, it didn't make any difference in terms of your prospects for dying over the ensuing 7 years. So that's not very encouraging result for that. Now, a large multi-center trial that I was involved in is called the Enhancing Recovery in Coronary Heart Disease, or Enriched Randomized Trial. We studied people who either had major depression or who had low perceived social support or who had both problems. That's kind of unusual to have a trial focusing on two different problems at the same time. The mainstay of treatment was cognitive behavior therapy. People were also given sertraline if they needed it, and the comparison was to usual care. The primary outcome was time to recurrent myocardial infarction or death. These are people who had just had a myocardial infarction. You can see here there was absolutely no difference in the outcome in terms of recurrent myocardial infarction or death. It was a really discouraging finding. But when we look at the depression data, we can see that there's a pretty modest difference on the Beck Depression Inventory, for example, between the groups. And we tried very hard. We got training at the Beck Institute for CBT. People got up to 6 months of therapy if they needed it. They even got some group therapy if they needed it. We really tried, and despite all of that, there wasn't that much of a difference between CBT and usual care. So that was also not very encouraging. However, a more recent Cochrane systematic review, I don't know if those of you who are familiar with Cochrane reviews, the people who do those reviews tend to be awfully damn stingy, especially with lifestyle and behavioral and psychosocial interventions. They almost never say there's good enough data or that the data are convincingly positive. It's very hard to get a blessing from the Cochrane reviews. And nevertheless, they showed in this 2021 review over 10 trials that psychological therapies like CBT tend to be more effective than whatever they're being compared to. For short-term outcomes, the evidence isn't very clear. They don't know about medium or longer-term outcomes. Probably not superior to controls for remission of depression, and no consistent effects on mortality or cardiac events. And antidepressant medications, on the other hand, seem to be faring better with more and more evidence. There is still high heterogeneity and low certainty evidence, but there seems to be a signal of superiority to whatever it's been compared to for remission of depression. And nevertheless, the remission rate for these first-line antidepressants like sertraline is only about 30 to 35%, which means most people who are getting treated with these drugs are not remitting. They may be improving, but they're not getting fully over their depression. And again, there's no consistent effects on preventing cardiac events or mortality. So we clearly need more work on treatments. Now, the same people who did the SAD Heart trial decided later on to do another SAD Heart trial, except this time, instead of with heart attack patients, they tried it with people who have heart failure. So they randomized 469 patients with heart failure and major depression to either get sertraline and placebo. And as you can see here, they're on this depression measure, the Hamilton scale, there turned out to be absolutely no difference between sertraline and placebo on the depression outcome. There's another famous trial called the MOOD-HF trial. This had 372 patients with heart failure and depression. They were randomized to a different SSRI antidepressant called escitalopram or to placebo, and favorable safety outcomes again, but no difference in all-cause death or hospitalization, depending on whether you got the drug or the placebo. Now, somehow, despite those discouraging findings, more recent meta-analyses are starting to show some positive signs. A couple of 2019 meta-analyses showed some favorable trends for CBT and for exercise, and not for antidepressants. The most recent meta-analysis, and one of the best, this has 25 randomized controlled trials and over 6,000 participants. This just came out in 2024. It shows the most robust effect is for CBT on improving depression. You get maybe a little bit of an advantage if you add exercise to CBT. And again, these are in people who have heart failure, right? Exercise by itself seems to have some benefit, but not very robust. And if we look at this was a Bayesian network meta-analysis, which means in plain English that some of the things that were compared to each other haven't actually been compared in real life. They've been compared virtually or statistically in this analysis. And we see here, when you compare CBT plus exercise to CBT alone, it gives you a tiny little bit of an advantage. It probably can't hurt, but it's not going to make a huge difference. We see when you compare exercise to CBT that the advantage goes slightly to CBT, not a huge advantage, but slightly. When you compare CBT to usual care or treatment as usual, there's a clear benefit for CBT. And nothing else much shows up. Exercise seems to be maybe a little better than usual care, but not that much. So the clear winner here in this latest meta-analysis is CBT. So I want to shift with that background to talking a little bit about our own research at our center here at Washington University in St. Louis. One thing is, I've done some work on depression as a barrier to self-care, and we see that it is a barrier. People who are depressed tend to not take as good care of their heart failure. And heart failure self-care is pretty important. You need to engage in self-care if you have heart failure in order to maintain your overall health and functioning, to prevent acute exacerbations of heart failure that can land you in the hospital, and also to slow the chronic progression of heart failure. Heart failure self-care includes several different kinds of things, including symptom monitoring, so that you're aware when you're going into an acute exacerbation. You can tell if you're getting shortness of breath, if your legs are swelling up, etc. You need to engage in long-term health maintenance behaviors like adhering to a low-salt diet, maintaining a certain level of physical activity, adhering to your guideline recommended medications. So those are all critical for maintaining your health. And also, if you do wind up detecting that you're having an exacerbation, what do you do about that? Do you further reduce your fluid and salt intake? Do you take diuretic medication? Do you call your doctor? What do you do in order to manage the acute heart failure symptoms? So all of those are really critical. And in one of the trials that we did, we thought, okay, since depression is a barrier to self-care of heart failure, what if we treat depression, and what if we incorporate self-care goals into the cognitive behavior therapy? Because after all, some of those self-care behaviors are some of the same kinds of things that we would talk to people in cognitive therapy about, like getting more physically active or doing more things to take better care of yourself. So we thought, great, let's fold that into cognitive behavior therapy, make those part of the set of goals that people are working on, make it part of their behavioral activation plans, and maybe that'll improve not only depression, but it'll improve self-care. We enrolled 158 outpatients with heart failure and comorbid major depression. And what we found was CBT was clearly superior for depression, but it didn't have any effect on self-care, unfortunately. And so we were glad to show pretty clearly this benefit on depression, but not too happy about the self-care outcomes. So we were trying to think, well, okay, what do we do about that? Well, maybe we could try a sequential approach, since integration of these two problems didn't work. What we thought was, okay, let's initiate CBT with an experienced cognitive behavior therapist, give them CBT for a few weeks to get them less depressed, and then get them started in a nurse-directed heart failure self-care intervention, because if they're less depressed, they ought to be able to benefit more from that than people who are not getting more that kind of aggressive treatment for their depression. We randomized 139 people to CBT or usual care, very good therapists that we had. This was an adaptive form of CBT where depression improvement criteria drove the frequency and duration of CBT. The intensive phase of cognitive therapy lasted anywhere from 8 to 16 weeks, and a maintenance phase went through week 32. And then after 8 weeks, whether you were in the CBT or the usual care group, you got started on a nurse-directed, individually tailored self-care intervention for heart failure self-care. It started at week 8 to allow time for improvement in depression. This lasted through 8 to 15 weeks. So this was often going concurrently with CBT, but people got started in CBT, 8 weeks before they started on this. And then they also went into a maintenance phase of the self-care intervention through week 32. So they got a lot of intervention. You can see here we got very nice, robust effects on depression over 32 weeks. It wasn't apparent by 8 weeks, but by 16 weeks, there was a clear difference and an even bigger difference in depression at 32 weeks. But when you look at, actually, I just want to mention anxiety. We weren't explicitly enrolling people for anxiety, but most people with depression and heart failure also are fairly anxious. And we got, even though we weren't explicitly aiming to treat it, we got nice effects on anxiety in addition to depression. But when we look at one of the standard measures of self-care, this is called the Self-Care of Heart Failure Index. We found absolutely no benefit on self-care between CBT and usual care group. Now, we looked further into the self-care outcomes, and we found that 77% of the patients scored in the inadequate range of self-care on self-care maintenance at baseline. And what we found is when people started in this individually tailored self-care intervention, that if you started with inadequate self-care, you tend to improve your self-care quite a bit. If you started with adequate self-care, you didn't get much out of going through this self-care intervention. Even though you had room to improve, people didn't tend to go from adequate to better or perfect, right? And in fact, if you started with inadequate self-care, about 48% of the patients by week 32 had adequate self-care. So this self-care intervention made a great deal of difference. But what we found is inadequate self-care at baseline predicted whether you're going to have a good self-care outcome. Higher anxiety, people that were more anxious about their health in particular did better. Higher doses of the self-care intervention made a difference, but neither getting CBT nor having less severe depression when you started the self-care intervention didn't make any difference. So some of the things we've concluded from these two studies is don't wait for depression to start working on heart failure self-care. You can work on these things at the same time, but you can't work on them in an integrated fashion. Heart failure self-care is best done by cardiac nurses, people that really are experts and can work intensively on self-care. You don't have to treat depression in order for them to be able to do that, even though depression is a barrier to heart failure self-care. You do have to coordinate these kinds of interventions because there's only so much intervention anybody can take at the same time. You got to kind of work in a teamwork fashion. The thing is, treatment of depression, even if it's successful, doesn't improve self-care. And I would say more broadly, we find in all kinds of different areas of research that if depression is a barrier to something, it might be a barrier to medication adherence, it might be a barrier to exercise, it can be a barrier to all kinds of things. But even if you treat depression successfully, that doesn't mean that those things are going to get better. In other words, treat depression, that doesn't mean that somebody's going to start exercising. It doesn't mean that they're going to start taking their medications. You need to intervene on those things too, if those are problems. Those are those separate issues. And I don't think we can assume any longer that treating depression is going to unlock people's ability to do other good things that we would like to see them do. We did a 1-year follow-up also of this trial, and we found sustained benefit on depression at 1 year, and we found sustained benefit on anxiety, and also a robust effect on heart failure-related quality of life. This is the Kansas City Cardiomyopathy Questionnaire. So people that got CBT did much better in terms of their quality of life over 1 year than other patients did. So to kind of summarize all of this, antidepressant medications seem to be safe on the whole for patients with heart failure, but they also seem to be pretty ineffective. Among non-pharmacological therapies, CBT has shown the best results so far. We need a larger multicenter trial to really pin this down. The downsides are it usually takes at least 8 to 16 weeks of CBT, requires really talented therapists, experienced therapists. The remission rate, even with this really good therapy, is only about 35%. Exercise also seems to be able to help improve depression, and it's also good for cardiac patients. In a way, you're dealing with two different objectives at once when you're trying to get people to exercise. But as far as improving depression, it's not as good as CBT is. And it's also hard to get people to exercise, especially if they have heart failure. But what do we need to do in terms of further research? We need to refine CBT to improve its cost effectiveness and efficiency. We've offered up to 6 months of CBT to a lot of the patients in these studies, and it's hard to imagine that being widely available in the healthcare world. And also, not everybody needs 6 months. So we have to figure out how to make this more tailored, more personalized, more cost effective, and more efficient so that it can have broader reach. We need to do some head-to-head kinds of comparisons, like how about comparing antidepressants to CBT? How about exercise versus CBT, an actual direct comparison? How about augmentation kinds of strategies, like adding CBT to exercise or combining antidepressant therapy with CBT? We need to test those kinds of approaches. We need to start thinking about more advanced kinds of therapies for people who aren't responding. Like if you don't respond to sertraline, what do you do next? Maybe transcranial magnetic stimulation might be a nice alternative. There are all kinds of interesting developments in treatment-resistant depression that might be brought to bear on depression in cardiac patients. And then, of course, we need to be thinking about stepped care, collaborative care, and integrated care models that might be able to deliver effective depression care on a broader basis, like within the context of primary care or within the context of cardiology care, rather than leaving everything entirely up to mental health care specialists. And of course, we know there just aren't enough mental health care providers to go around, especially not in medical care settings. So to summarize, depression is common in patients with coronary heart disease or heart failure. It increases the risk of adverse outcomes, like your chances of dying after a heart attack are about doubled if you're also suffering from depression. If you have depression and heart failure, you're likely to wind up in the hospital a lot more often. So these are really consequential problems. Unfortunately, it's a hard to treat problem. We have a lot to learn about how to treat it. We need to do more treatment development work and more rigorous randomized controlled trials, including multi-center trials and comparative effectiveness trials. And I would say to anybody out there who's looking for important, significant, and promising areas of research, this is a great one to get involved in. It's wide open and the needs are very great. And especially because heart failure is predominantly a disorder of the elderly, and its prevalence, especially in America here, is increasing as the population ages. Just a few readings I would like to recommend. Bob Carney and I and colleagues have done a couple of review papers that I think will help cover some of the things I've talked about, as well as some other issues, like, for example, what are the kinds of mechanisms that may link depression to bad outcomes in heart disease. And then also there's a relatively recent review that looked not only at depression, but also at anxiety in patients with heart failure. So with that, I will stop, and I guess we have time to entertain some questions.
Yes, thank you for the fantastic talk, Ken. That was wonderful. I know I have some questions, but before I jump into my questions, I'd like to open them up to the room.
Do you want people to post the questions or to ask them out loud?
If people can speak up, that would be great. I believe folks can unmute themselves.
Hi, this is Jayesh Kamath here. Take the first one. Thank you for the wonderful talk. I have a couple of questions, one specifically about the medications. One of the things that we know about antidepressants that some are associated with QTC prolongation and others are not.
Yeah.
Is there anything in the literature or otherwise that can you comment on that in terms of use of antidepressants? I know certainly is a good one, but otherwise QTC prolongation, has that been an issue when antidepressants are used in this?
Yeah, it can be, especially with like the older tricyclic antidepressants. That's why one of the reasons why the SSRIs tend to be the first line antidepressant treatment with these patients. Is that doesn't seem to be a major problem. I think on the whole, most of the evidence for those kinds of antidepressants like sertraline and citalopram tend to be pretty favorable. There are antidepressants that people should stay away from if they have heart disease. I don't want to go too far into that because I'm not a psychiatrist, and so, but there are some good reviews of antidepressant risks and benefits in cardiac patients. One of the things I would point you to is we have a chapter in Braunwald's Heart Disease, kind of the classic heart disease textbook. I think the latest one that's published is the 12th edition, 2022. We have a new edition coming out for 2025. And there's a pretty nice lengthy review in there of medication issues. So I would point to that, and I think there's also been some other review papers. But yeah, I would say just in general, it's maybe one more reason why cognitive behavior therapy and exercise are worth giving serious look, because not only are occasionally there are safety questions about antidepressants, but people, by the time they have a problem like heart failure, they tend to be on a whole bunch of medications already. Lots of people don't want to be on one more medication. So if you can find a non-pharmacological alternative, that's often, for many people, is desirable.
And just one quick question about the CBT and exercise, I guess. Are there any effects on, or are there any positive effects on morbidity, mortality, and functionality?
Again, we have very limited evidence. Now, functionality, yes. I mean, people, that quality of life outcome that I showed you, you could almost think of that as a functional outcome. When people's depression improves, not only in the trials I've been showing you, but in other trials as well, functional outcomes and quality of life tend to improve along with it. So yeah, there is some benefit there. In terms of medical morbidity and mortality, we have not really developed a lot of convincing evidence that treating depression translates into those benefits. We don't know why not. We think because it's a risk factor and an adverse prognostic factor, we have hope that treating depression may improve those kinds of medical outcomes. But so far, we don't have a whole lot of evidence to support that. And I think that's an important direction for future research, continuing research, but it's a difficult one too, because you need to do large studies with longer term outcomes. And of course, those are expensive and difficult. And I think it's going to be a while before we really have good answers to that.
Thank you.
Looks like Stephen Amrock, your hand is up. While we're waiting for Stephen, there is a question in the chat from Neha Jain. Great presentation. Would you be able to comment on the persistence of the effect of CBT? Does the beneficial effect continue indefinitely or start to taper at some point?
Interesting question. As you saw in that one slide, we did a 1-year follow-up and saw robust benefits that lasted for a year. Now, when I say robust, I mean, people improved, but only, I think if you add it all up, only 30 to 35% were still in remission at 1 year. And so there's lots of people that, despite all of that CBT, and for many of them also trying an antidepressant, they still had some degree of depression. The thing about CBT that's different than many other kinds of interventions is part of it is aimed at imparting skills to patients that they can apply to their own lives over the long haul, problem-solving skills, understanding of the benefits and strategies for behavioral intervention, behavioral activation, mood regulation strategies. So those things can be learned and can be applied moving forward. And hopefully when people get better and stay better, part of the reason is they've learned something about how to use those kinds of skills. That's different than treatment with something like an antidepressant, where if you go off an antidepressant, there's very little keeping you in remission other than good luck.
Great, thanks, Ken. So Stephen has put his question in the chat. So sorry, technical issue. Wondering about effect modification or heterogeneity of effect by etiology of heart failure, for example, stress cardiomyopathy. Were the trials focused on ischemic cardiomyopathy specifically?
No, they weren't focused on any particular kind of cardiomyopathy or heart failure. The reference to stress cardiomyopathy, there's an interesting phenomenon called Takotsubo cardiomyopathy that apparently is caused by extreme stress or traumatic stress. It's more prevalent in women than in men. It's kind of cause a apical ballooning of the heart. And so that's an interesting phenomenon where stress has been very directly linked to a bad heart kind of a problem. But we don't really have any evidence that I'm aware of that the etiology of heart failure or the type of heart failure has anything to do with how we treat depression. And I would also just want to mention, it's been thought for many, many decades that there are all kinds of different cardiomyopathies. Cardiologists have long thought that alcohol is a cause of cardiomyopathy and a cause of heart failure. More recent evidence has cast doubt on alcohol as a cause of cardiomyopathy. There's even something they call alcoholic cardiomyopathy, but there's really doubt on that. Alcohol, in contrast, if you have heart failure and you're using it, it's a bad thing. There is stronger evidence linking use of stimulants like cocaine or methamphetamine to cardiomyopathy. But all of those kinds of substance use problems are also interrelated to depression. And so when we think about, even though depression is one of the most common and consequential psychiatric problems in heart patients, it's not the only one. We need to think a little more broadly about PTSD and substance use and anxiety and other kinds of problems that people are having. But I would say if you had to pick one, probably nothing more important to work on than depression.
Thanks, Ken. Another question in the chat. Madison Tillman writes, you mentioned that heart failure is especially prevalent in the US. How would you expect some of your findings to change if you were to study patients outside of the US? Do you know if depression is also persistent in people with heart failure outside of the US?
Yeah, there's been a lot of interest in these issues in in Europe, especially in the Netherlands and in Germany. China, there's been an explosion of interest in psychosocial and behavioral factors in heart disease, and some very, very large studies over there. So as far as we know, and also the Mood HF trial that I mentioned, mostly done in European centers. So there's actually been quite a bit of work outside of the U.S. On this, and as far as I can tell, there isn't any systematic difference. People may arrive at heart failure in different ways, in different ages, for different reasons, in different places. But basically, when we look at the behavioral side of these problems, we're basically working on the same phenomenon across countries.
Thank you. I do not see anybody else's hand up right now. Okay, so I guess I have a question for you, Ken. I'm really interested in this idea of mechanisms. And as a clinical health psychologist, the connection, the genetic connection between depression and heart failure, yet a lot of no findings, right, in terms of the treatments actually panning out and in terms of affecting heart failure. And so I'd be curious just to hear about your thoughts on that, if you have any hypotheses as to what could be operating there. I'm thinking a lot about behavioral risk factors, and with my obesity treatment hat on, thinking about how mood affects diet, oftentimes emotional eating, physical activity, increases sedentary behavior, and also the findings in obesity treatment that we show that weight loss actually significantly improves symptoms of depression. And so I guess with all that, I'm just curious to hear your ideas about mechanisms, and also any thoughts on the literature on obesity treatment in this space.
Well, let me talk about mechanisms first. There's been much more research on biobehavioral mechanisms relating depression to coronary disease than there has been in heart failure. It's been not that much mechanistic research in heart failure, but in coronary disease, there really are two different sets of candidate mechanisms. There are the lifestyle factors, such as physical inactivity, smoking, obesity, poor diet, and other kinds of behavioral and lifestyle problems is one thing. And then on the other side, there's been a lot of interest in various kinds of biomarkers, particularly inflammatory biomarkers that might link depression to coronary outcomes. And we actually, at our lab, were one of the centers that was working on one possible way of intervening if inflammation is indeed an important mechanism. We were trying to see whether augmenting antidepressant medication with omega-3 fatty acids would make any difference. Some people looked at omega-3 as a treatment in its own right. We were looking more at omega-3 as an augmentation for antidepressants. Found absolutely no effect. And that's over 2 different trials. So there are those kinds of biobehavioral mechanisms, and then there's a whole set of lifestyle interventions. There has been a lot less on linking diet and obesity as it connects depression and heart disease than there has been for physical inactivity, sedentary behavior, and exercise. That's probably been a stronger area of work. But all of those things are potential candidates. And here again, going back to what I was saying a while ago, one of the things we keep learning is just intervening in depression isn't going to improve those things, even if they are mechanistic links. If poor diet is related to depression, or if physical inactivity is related to depression, just improving the depression isn't good enough. It's not enough. You really need to intervene on those other problems.
Yeah, and just thinking about obesity treatment, oftentimes like I said, we see improvements in depression, and it can actually be beneficial when individuals start losing weight. Of course, there's a lot of positive reinforcement with weight loss, reduced pain, social reinforcement, and improvements in a variety of health outcomes. And sometimes the physical activity is really difficult, initially because of excess adiposity. And so that can actually be a barrier, the pain associated with being active. And so it just seems to me that that initial weight loss could be a way of activating individuals and addressing mood, and which could then have a downstream effect eventually on physical activity when individuals become more capable of physical activity because of reduced pain, because of reduced weight. So just thinking about all of these factors and how they play in with weight management interventions.
I think that's fascinating, and I think that's a wide open area to look at how treatment of obesity might have benefits on depression in cardiac patients. The one thing I would caution is there's a kind of a weight paradox in heart failure. As people's heart failure advances, losing weight can be a really bad sign. And so you have to kind of be careful about how and why you're intervening in people's weight when they have heart failure. But other than that, I would say this sounds really like a promising area to look at of how intervening in diet and exercise might benefit comorbid depression.
Great. Well, thank you so much, Ken. It's just been an absolute pleasure, and we're very grateful to have you here today. You're such an esteemed colleague and a tremendous leader in this space, and thank you so much for your time.
Well, thank you for inviting me, and thanks to everybody for your attention. I've really enjoyed talking with you about this.
Thank you.
Take care.
You as well.